Tonsillopharyngitis is acute infection of the pharynx, palatine tonsil, or both. Tonsillopharyngitis is usually viral, most often caused by the common cold-causing virus such as adenovirus, rhinovirus, influenza, coronavirus, and RSV. In about 30% of patients, the cause is bacterial. Group A beta hemolytic streptococcus is the most common, but sometimes Staph aureus, strep pneumonia, Mycoplasma pneumonia, chlamydia are sometimes involved. Group A beta hemolytic streptococcus occurs most commonly between ages 5 to 50 and is uncommon before age 3. When we see signs and symptoms of tonsillopharyngitis, pain when swallowing is the hallmark of tonsillopharyngitis and is often referred to the ears. Very young children who are not able to complain of sore throat often refuse to eat. High fever, headache, and GI upset are common, as are halitosis and muffled voice. The tonsils are swollen and red and often have purulent exudates. Tender cervical lymphadenopathy might be present. Fever, lymphadenopathy, palatal fatigue, and exudates are somewhat more common with group A beta hemolytic streptococcus than with viral tonsillopharyngitis, even though some overlap are there. With group A beta hemolytic streptococcus, a scarlatiniform rash or scarlet fever might be present. Group A beta hemolytic streptococcus usually resolves within 7 days with or without antibiotics, but untreated group A beta hemolytic streptococcus may lead to local suppurative complications such as peritonsillar abscess or cellulitis, and sometimes it might lead to rheumatic fever. Clinical evaluation is needed to diagnose tonsillopharyngitis. Then group A beta hemolytic streptococcus should be ruled out by rapid antigen test, culture, or both, routinely or selectively. Pharyngitis itself is easily recognized clinically, however, its cause is not. Rhinorrhea and cough usually indicate a viral cause. Infectious mononucleosis is suggested by posterior cervical or generalized adenopathy, hepatosplenomegaly, fatigue and malaise for more than 1 week, and a full neck with petechiae of the soft palate and a thick tonsillar exudate. A dirty gray, thick, and tough membrane that bleeds if peeled away indicates diphtheria. Because group A beta hemolytic streptococcus requires antibiotics, it must be diagnosed early. Rapid antigen tests are specific but not sensitive and might need to be followed by culture, which is about 90% specific and 90% sensitive. Many authorities recommend using the following 4 criteria of the modified center score: fever, tonsillar exudates, absence of cough, and anterior cervical lymphadenopathy. Each of them have one value, and patients who met one or no criteria are unlikely to have group A beta hemolytic streptococcus as a cause of pharyngitis and they should not be tested. Patients who met 2 criteria can be tested. Patients who met 3 or 4 criteria can be tested, or they can be treated empirically for group A beta hemolytic streptococcus. Supportive treatment for tonsillopharyngitis include analgesia with, for example, paracetamol, non-steroidal anti-inflammatory drug, or local analgesics. Hydration is also important, and having rest is appropriate. Amoxicillin is the first line of antibiotic treatment, and amoxicillin clavulanic acid can be used in high amoxicillin resistant area. If adherence is a concern, a single dose of benzathiopenicillin is effective. Other oral antibiotics include macrolides such as azithromycin or clarithromycin for patients allergic to penicillin, and first generation cephalosporin and clindamycin can also be given. Diluting hydrogen peroxide with water in a 1-to-1 mixture and gargling with it will promote debridement and improve oropharyngeal hygiene. Tonsillectomy has often been considered if group A beta hemolytic streptococcus tonsillitis recurs repeatedly. For example, more than 6 episodes per year, or more than 4 episodes per year for 2 years, or more than 3 episodes per year for 3 years. Or tonsillectomy can also be considered if acute infection is severe and persistent despite antibiotics. Other criteria for tonsillectomy include obstructive sleep apnea, recurrent peritonsillar after, suspicion of cancer is an indication for having tonsillectomy. Decision should be individualized based on patient's age, multiple risk factors, and the response to infection recurrences. Thank you for watching.